Good day and welcome to another Podinar from this series of the Podinars from the Global Summit Institute. My name is Dr. Sonia Aykroyd, and today I'm going to be your host. I'm going to be hosting Dr. Marco Castro. I am a dentist, a researcher, and an entrepreneur, and I'm very pleased here today to present you with this amazing speaker, Dr. Marco Castro, who will talk about healing in diabetic ulcers and how his experience with platelet-rich fibrin healing. And just a reminder, at the end of the webinar, the Podinar, you can click on the link below and you are able to register to acquire your CE credits. So before we proceed, I would like to introduce Dr. Marcos in a proper way. So Dr. Marco Castro, he was born in Guatemala City, and he studied his first dental degree at the Universidad Francisco Marroquín in Guatemala City. After completing his DDS program, he entered the advanced prosthodontic program. And after completing that, he was accepted the UCLA, the UCLA, to do a course in advanced clinical training in surgical implant dentistry. So Dr. Castro has been a contributor to Understanding Platelet-Rich Fibrin book published by Quintessence. He has been working hand in hand with Dr. Rick Miron in the use of PRF for extraoral chronically non-healing wounds. Now, Dr. Castro is working on refining the technique to close non-healing chronic wounds, especially in diabetic foot ulcers. Dr. Castro has recently got a certificate on scientific investigation, which he studied in San Carlos University of Guatemala. He was given the privilege to become a dean at the School of Dentistry at Montemorelos University in Nuevo León, Mexico. Currently, Dr. Carlos is working with a team of various projects related with PRF. He works in close relation with other universities, such as the Autónoma de Nuevo León, Centro de Investigación y Desarrollo en Ciencias de la Salud, Dr. Miriam Angélica de la Garza Ramos, and New York's and Nova University through Dr. Ricky Miron. Sorry, Dr. Castro, this was is such an amazing CV that I had to read it, and there was, let me just stop sharing, because now I would like to talk to you. Please tell me a little bit about your work. How did you get like from one area to another? How did you end up doing what you're doing now?
Hi, Dr. Sonia. It's a pleasure to be here with you today. How I ended up treating diabetic foot ulcers. It's a good question because I'm a dentist. But all of this started back in 2014 when I started using PRF. I started using another protocol that I don't use currently, the Intraoral Protocol. But when I get back from California to Guatemala, where I used to live, I started doing PRF, you know, for mouth, for all of the dental applications, right? And facial aesthetics. But then it's well known that PRF has a great healing capacity, wound healing capacity, and the growth factors and everything. So an aunt of mine, they told her, listen, you have diabetic foot ulcers and we're going to amputate your foot. So I told her, why don't you let me try this on your foot, because it works spectacularly on the mouth. So maybe we can try it on your foot and let's see if it works. Because she had this diabetic foot ulcer for 2 years, and she had chronic renal failure, diabetes, hypertension. She went every 3 days to hemodialysis, and she had a lot of issues, medical issues. So they told her, either you get this amputation or you're probably gonna die. She had recurring infections, and so since I had my own private practice, I do work with anesthesiologists. So I told my anesthesiologist, listen, doctor, can you help me with this? This is something that I want to try, because I don't want my aunt to get an amputation. So we started to, first of all, to clean the wound and prepare it for receiving the PRF. And thank God, and sure enough, after the third PRF application, we started seeing major changes, like in the size of the wound, the quality of the tissue, tissue healing. And it was amazing because all of the medical issues that she had, she also had uh, um, hypercholesterolemia, so high cholesterol levels, and all of this, sugar and cholesterol, it kind of make the PRF not so effective. So we had to do a little bit of diet with her, and we had to get all of her blood samples right after her dialysis. So it was a challenge, but that we saved her foot. And she was the first case that we did. And in 2.5 months, her ulcers were closed. And we were very pleased with the results. And since that patient, we've been working. Right now, we have somewhere around 38 or 40 patients, and we have more that we're working on them with 100% of success. And the closure. Today, I'm going to show some cases that we're going to see, very interesting cases. And basically, that's how I got into this diabetic foot treatment.
Amazing. And it was the challenge that the thing that you could think out of the box and transport the knowledge from one area to another, right? Was very important to it. So do you know this center where you treat these patients, it look like a university center, or is your own private practice? How is that set up?
No, not, I started at my own private practice, but now I am at the university. I work here, university based, and we do all of the patients here. Currently, we are starting we will start a trial very soon, because we want for this to get the FDA approval. So we will start it very soon.
All right, fantastic. So we want to hear more about it. So now you can share screen and start telling us all of this amazing contribution you've done to science.
Yes, of course. So the topic is going to be chronic wound healing using Bio Prf. And this is my contact information. If by any chance you want to contact or any research opportunities, we are open to make research with doctors, from all over the world. And this is what has us here today, right? The PRF. We know all of the benefits that PRF has, growth factors. Basically, the one that we will be looking today will be VEGF, or VEGF, which is a vascular endothelial growth factor. This is the one that has us here, right? Because it'll be the one that will close the wounds with the neovascularization. PRF has many uses throughout the medical field, not only on the dental field. This is very important. I do work with a team. It's not only me. This is my team, Dr. Sosa, Dr. Sierra, Dr. Alvarez, Dr. Castellanos, Dr. Rutia, and Dr. Piña. We do make a team, and it is very important because all of us have a different expertise, and it's always important to have a good team, good people surrounding you, because they're going to help you. So we will see a little bit of basic science before we go through the cases. And PRF, it's very simple. We used to have PRP. Well, it's still used, but today we have PRF. PRF, basically, it's like a second generation PRP, where it's very simple. Just extract the blood and centrifuge, and then you have your PRF. You don't have to do a 2 centrifuge protocol. It's just a 1 centrifuge in this case, we are using the horizontal centrifuge, so the Bio Prf centrifuge. We have different tubes when we want to work with PRF. The red tubes are for solid PRF, solid membranes, and the white tubes are for liquid PRF. So if we want to do, like, for example, wound healing, we would use a mixture of red and white tubes. If we want to work, for example, with facial aesthetics, it would be white tubes, because we will need to inject. So the white tubes are for injectable, and the red tubes are for solid PRF. These are some of the uses of PRF. I think all of you doctors are very knowledgeable on this and know the different and various applications that the PRF has. And basically on dentistry, we have, for example, sticky bone, PRF membranes, and we can also use it for facial aesthetics and many other different applications. This has been the development of the PRF. We started with PRP over in 1998. We do use some additives. And then in 2001, Intralox introduced the PRF, the proper PRF, the Lprf Protocol. Then 2014, Dr. Shukroon, Aprf, 2016, Aprf Plus, and 2016, Iprf. And in 2019, it came out the Bio Prf Protocol. I've used personally, I do have the 3 centrifuge, the Intralock, Shukroon's, and Bio Prf. Currently, I am only using the Bio Prf because clinically it has better results. And there are some studies that I will show today that shows why it works better than the regular centrifuge. The difference between Bio Prf and the rest of the PRF is that Bio Prf uses a horizontal angle centrifuge, and it works in G-forces, not in RPMs. And Lprf and Aprf, they work with RPMs, and they do use a fixed angle centrifuge, right? We will look at this. But basically, the difference between PRP and PRF is the use of anticoagulants. And often PRP uses 2 spin cycles. PRF is just a plain tube, no anticoagulants, and it's only 1 spin cycle. And the difference is the cellularity, right? The leukocytes, the difference in leukocytes concentration. This is just a a picture of the cells, the form of the cells that we have. And this is why it's so important for us to know how are we going to distribute our cells throughout our membrane, our PRF membrane, right? This is a paper from Anitwa, right? Back over at 1999. He's been the author for Plasma-Rich in Growth Factors. But interestingly, he stated in this article in 1999 that to improve healing, remove the anticoagulants. So even Anitwa, well, he had to realize this because it is the major difference. We don't use anticoagulants when we use PRF. This is a fixed angle centrifuge. So, for example, this is the Intralock. They are at 33 degrees angle. When they spin, your blood is at a fixed angle, 33 degrees. And when we spin the PRF or your blood over a horizontal, it's at a 90-degree angle, right? So it has many advantages, like the force, right? And the better distribution of cells throughout our membrane. So this is the centrifuge that we are currently using, the Bio Prf. And as I stated, there are many centrifuges in the market. It's not the same, right? It is very important to say that. Some use different protocols, some use different angles for centrifugation, some use different tubes. So it's very important for us to work with the right centrifuge. This is the horizontal centrifuge that we use, and this is how it works. It's like a swing out bucket. When it starts spinning, the bucket will come out like that, like it's being shown in the video, and it becomes completely horizontal. So the separation of the cell layers will happen at a horizontal angle, and this allows for the cells to have a better distribution, because when I showed the picture, you can see clearly that leukocytes, platelets, and red blood cells have different sizes and different dimensions and different densities. So when we separate the cells, it's separated based on their densities, right? Again, with this picture is to show that when we centrifuge at a fixed angle, the one on the left, versus a horizontal angle, the one on the right, as you can see, the forces distribute better. And basically, the way to see if your doctor is using a horizontal angle or a fixed angle is at the Buffy Coat. The Buffy Coat is the interface between the red blood cells and the PRF. So in this diagram would be the white small coat between the yellow PRF and the red blood cells. That's going to be the Buffy Coat, and basically the Buffy Coat has a lot of cells. It's very rich in cells, very rich in leukocytes, and basically the platelets will be distributed through the PRF, so through the yellow layer, and the leukocytes will be over at the Buffy Coat, so the white layer. Okay, so this is what happens at a fixed angle centrifuge. you can only get around from somewhere from 200 Gs to 400 Gs max over at the bottom of the tube and 200 over at the top. And when we work at a horizontal angle, we can get all the way over to 700 Gs, right? So we can distribute our forces in a more efficient way when we work with a horizontal angle. And this is what I was stating previously, that when you work at a fixed angle centrifugation versus a horizontal centrifugation, you can see your Buffy coat. Your Buffy coat will be angled over at a fixed angle centrifugation, and it'll be flat or horizontal at a horizontal centrifugation. The main advantage of the horizontal, as I said previously, is that it produces a linear separation of your cells, right? Versus the horizontal that will create a cell accumulation at an angled fashion, right? So here we can see it on the tubes, right? And versus the diagrams. Here on the tubes, you can see clearly which one's which. The one on the right, it'll be the fixed angle, where you can see the angulation, 33 degrees, versus the one on the left, that it's horizontal one. And you can't see it here, but I think I have another picture. I will show you this. Very interesting. So here the G forces are more evenly distributed, and you can see the cells can distribute more evenly throughout the bottle instead over the fixed angle, where the G forces push the cells over to the wall, to the outer wall of the tube, and sometimes the cells tend to break, right? And we will see this picture. I think it's coming next. Here you can see a diagram of how the cells are being distributed, right? Here in a more linear fashion for the horizontal, and when we use a fixed angle centrifuge, all of the cells tend to pack toward the outer wall of the tube, and this not only interferes with a good cell distribution, but also it tends to break some of the cells, right? So this is why for some of the protocols that we use when we use a fixed angle centrifuge, some of the cells of some of the platelets and the white blood cells are down in the red blood cell layer, which this shouldn't happen, or compared with the horizontal, this doesn't happen, right? Because the cells can distribute more in a more evenly fashion. And this is what I was telling you. You can see clearly here the red blood cells, right, that have gone to the upper layer, and obviously some of the platelets and white blood cells have gone to the lower layer. This doesn't happen with the horizontal centrifuge, and you can see here an example of what happens. So this is why we can say that with the horizontal centrifuge, we can get a more evenly distribution of the cells. So this is very important because, as I stated previously, that the density of the cells are different, right? So and the shape is also different. So this is how we know how this works, right? Through the density of the cells. It's how we get the separation of the cells in the tube, right? So basically we have three cells: the platelets, the leukocytes, and the red blood cells. And we have many bioactive molecules within the PRF, right? The platelet-derived growth factor, vascular endothelial, insulin growth factor, endothelial growth factor, transforming growth factor, and bone morphogenetic protein 2. Many growth factors within our PRF membrane. This ones that you're looking here are probably the most important and the most that we can get the use of them, right? But the PRF also has another interesting quality, that the matrix, so the matrix of the PRF, apart that it has all of these bioactive molecules, is also contains fibrin, also fibronectin and vitronectin. And this works like a mesh of support for all of the cells and for different uses, right? So it works like a highway, you know, like a highway for cells to move within. So this is why it's very important, the fibrin matrix of the PRF. Again, the BEGF is for angiogenesis. The platelet-derived growth factor is for the recruitment of the cells. And the transforming growth factor beta, it's for the proliferation of the cells, right? This is very important for us to know that the quality, the function of our growth factors. This one is a original article by Dr. Myron, and it's a novel method for evaluating and quantificating the cell types in platelet-rich fibrin. And so what they did is that they used fixed angle centrifuge versus a horizontal angle centrifuge, and they spin the blood samples, and they got the PRF right, PRF matrices, and then they separated basically the PRF from the red blood cells, and they got the PRF, so the yellow part of the PRF, the tube, the PRF properly, and they put it in another tube, and they analyzed, right, for cell count. And what they found is with the Lprf protocol, as you can see here, the majority of the cells were found within the Buffy Coat. So the Lprf protocol is 12 minutes at 700 Gs, and Aprf protocol, it's 8 minutes at 200 Gs. So the platelets with the Aprf protocol, it's cells are more evenly distributed through the PRF properly, right? So with Lprf, cells are packed within the Buffy Coat, and with the Aprf, they're more evenly distributed throughout all of the layers of the PRF, right? Basically, the Aprf protocol, it's a low-speed centrifugation concept, right? I don't know if you're familiar with that, but what Dr. Shukroon did is it's called the low-speed centrifugation concept. So basically, what we have is when we draw our blood, we will have a tube with blood, then we will centrifugate it. In this case, with a horizontal centrifuge, and then we separate our cells layers. We get our red blood cells and our PRF. So basically, what they did at this study is they separated the tube into 10 different layers, and they micropipette every layer out of the tube, and then they analyzed every layer with a cell count device. So this is how they did it, micropipetting every cell layer out of the tube, right? Until they got until the 10th layer. And then basically we, Dr. Myron, analyzed every layer in a cell counting device. And this is what he got, right? These are basically the experiments, right? But these are the results. The fifth layer, as I said earlier, is the Buffy Coat. And you can see here clearly for leukocytes, for platelets, and for lymphocytes are their highest counts. But on the layer 1, 2, 3, and 4, there are basically no cells, right? This is very interesting. Now, this is for Lprf. Now, for Aprf protocol, we can see here for leukocytes, platelets, and lymphocytes. And we have over a layer 1, 2, 3, and 4 for leukocytes, a small quantity, but for platelets, we do have more in layer 1, 2, 3, and 4. And also for lymphocytes, very, very small amount of cells. And here's the comparison, Lprf versus Aprf. And the big difference here is the platelets, right? Because basically they're intralock, so Lprf and Aprf, it's chocrunes. They both use a fixed angle centrifuge, but Aprf uses a low speed centrifugation concept. And we can see the advantage here, where we can get more evenly distribution of the cells throughout the layers, especially for the platelets, where you can see platelets for Lprf in layer 1, 2, 3, and 4, it's almost no platelets. And platelets for Aprf in layer 1, 2, 3, and 4, we do have a significant amount of platelets and a statistical significant difference, right? This is very interesting. So this is again a diagram of what we just saw in the graphics. Basically, for Lprf, all of the cells are packed within the Buffy Coat, and for Aprf, the cells are more evenly distributed throughout the Prf. Also, with the Lprf, we usually get a bigger membrane, and for Aprf, we get a smaller membrane, but more concentrated. And also remember that Aprf uses a low-speed centrifugation concept versus the Lprf protocol. So again, this is just talking about the layers, the cells. And this is another study, but this time we used a fixed angle centrifuge comparing with a horizontal centrifuge, right? We did the same protocol. This time we divided the tube into 4 layers instead of 10. We divided the tubes into 4 layers, and our results are pretty much the same as the previous results, where we got a significant difference. As you can see, the dark gray is for the horizontal, and the light gray is for fixed angle. And we got a statistically significant difference into cell counts for lymphocytes, neutrophils, and basically the white blood cells. So when we get horizontal centrifugation, we can get more cells, more cell counts, better distribution compared with Aprf. So in this case, we're comparing Aprf with Bio Prf or horizontal centrifugation, right? So now, this was just a small introduction of why we use PRF for chronic wound healing. And I just wanted for you to have an idea of what we are using. So we are using currently Bio Prf protocol. As I stated at the beginning, the Bio Prf protocol, it's done in a horizontal centrifuge. It works with G forces, The advantages is that they have better cell distribution, more cell count in the PRF matrix, and based on this, and also on clinical results, because as I stated at the beginning, we do have 3 centrifuges here, and we can use different protocols, but we've seen clinically that the Bio Prf protocol works better. And also the literature supports what I'm saying, because it has a better cell distribution and it has more cell count, right? So today I'm going to present some cases that we have. We will start with the case presentation for the chronic wound healing technique. The technique is called MCAS5 technique. Has 5 steps that we have to go through before the wound closure. And as I stated at the beginning, it's all of this began because of my aunt, that they were gonna make a foot amputation. So since we have PRF for various dental procedures and it works magnificently, we tried to give it a shot at the foot, right? In the beginning, we didn't have a protocol per se, because we had to develop it. There was no protocol. And we worked hand in hand with an anesthesiologist called Romeo Leiva, Dr. Romeo Leiva. We developed a protocol with him and Dr. Avi Diaz and myself. So basically what we did is we developed 5 steps and different injection techniques for the PRF and different centrifugation protocols for the application of the PRF directly to the wound, right? And we can see here we have 10 cases. Today I'm going to present 3 cases only, but for this 10 cases, the success rate was 100% with 100% closure. So PRF depends on the quality of your blood, right? So I'm gonna say that it is very important for your patient to have their blood sugar under control, their lipids under control, and a well-balanced diet. Good hydration is also very important. And we usually, part of our protocol, it's a nutrition follow-up of our patient, because we need good blood quality in order to get the wound closure. So we need blood sugar control, lipids control, and all of this is going to help us, right? So we will start with the first case today. Case number 1, this patient had amyotrophic lateral sclerosis, and he was on bed in a hospital, and the nurses, well, they didn't move him, so he got a pressure ulcer, right? This is a very young patient. He has 22 years. Currently, he cannot move. Basically, he cannot move. He has only partial movement of his left hand, but he cannot roll by himself in the bed. So he's dependent on the nurses for him to roll him, which is they didn't do that, and this is why this patient got this the pressure ulcers, right? So this is you can see here clearly, this is the first visit, and we started working on the upper ulcer. Take a look. The upper ulcer is already closed here. Now we're gonna go and close the lower ulcer, right? As at the MCAS5 technique has different steps and different techniques depending on the situation that you're gonna be working on. And for here, it's very difficult because this patient, as I stated before, he cannot move. So it is very important for the nurses to roll him because he cannot be all of the time on his back, right? Because they are pressure ulcers. And look at the progression. This is the fifth application for this patient. You can clearly see the upper ulcer is already closed. The lower ulcer is closing. So we do one application every 7 days, right? It's part of the protocol, one application every 7 days. And see, this is the fifth application, and you can see a significant closure of the wound. This is the sixth application. You can see how it's been closing. And this is the final resolution with 8 applications for this patient. You can see a complete remission of the ulcers or complete closure of the ulcers. And I will show some other case later on, but you can see also in this case, you can see on the smaller ulcer, the smaller upper ulcer, if you look closely to it, you can see the microvasculature. You can see it clearly in there. And that's the work of the VEGF, or vascular endothelial growth factor. This is an area that it's very difficult to close because it's almost it's very close to the bone. So our circulation wasn't as good for this patient. So, but you can see clearly the work of the VEGF. It closed both of the wounds at 8 applications. So for him, we took 2 months. His treatment was 2 months, right? In only 2 months, we were able to close the wounds. This is another patient. This patient has venous insufficiency, and she also has diabetes, right? You can see a wound over at her dorsal part of her foot. And she had this wound for over a year and a half. She had been using honey and several household medications, and nothing seemed to work. She also went with another doctor that told her that he could use hyperbaric therapy, but due to costs, she couldn't afford it. So this patient was scared because one of her neighbors, which was a doctor, told her that if this could get infected, well, she could get a foot amputation. So finally, she came to us, and we did the technique with her, and she closed very fast. She only had 4 applications, which means 1 month, right? She had venous insufficiency and also diabetes, but you can see the response of the tissue, right? This is you can see it's almost closed in here, and this is the complete closure. And look at the closure. It's very nice. It's very smooth. So we get a complete closure, and since PRF has fibroblast growth factor, it also enhances the quality of the tissue, right? You can see it's a good quality of tissue, a good healing. But this patient, as I said in the beginning, she also went with treatment with the doctor for her blood and for her blood, for her sugar in blood, it is very important to control her sugar in blood. So once again, sugar in blood is very important to be under control. And the lipids, so the diet, and also the hydration. If we have developed a protocol for our patients, they have to follow strictly. If the sugar is not under control, this treatment can be longer, right? Instead of 2 months, you're going to be 4 or 5 months under treatment, right? So the control of the blood sugar is very important. This is another patient. This is an abdomen non-healing wound. It had 7 centimeters of depth, right? 7 centimeters is it's a lot. And this patient had an abdominal surgery. The wound did not close. It has a lot of tension, so it was not closing. As you can see here, she had 3 months with this problem. She was scared. She was angry with the doctor. And well, the doctor referred her to us. So we were her last hope, and we started working with her. And you can see this is the 3rd application here. You can see the 3rd application. You can see how it's been growing from the inside out, and the quality of the growth, of the cellular growth, right? Take a look at that, how it's growing. This is the 4th application, right? It's almost closed. The 5th application, right? And this is the 6th application. So she was a month and a half with us for us to completely close that wound. And I put an arrow in there because it's very, very interesting. As I was saying, look at the microvasculature. We have noticed that the majority of our patients have this kind of microvasculature, and this is amazing. And this is the work of the VEGF, right? The vascular endothelial growth factor. Without blood, without good blood flow, there is no healing, right? So this is why the VEGF is very important, because it will help the tissue to heal, because it will create neovascularization, and it will create healing, because it doesn't heal because there is no vascularization, basically, and no tissue can form without neovascularization. So this is why, and we have noticed this, that all of our patients develop this kind of neovascularization. And this is the case that I was talking about in the beginning. This is my aunt. She had this diabetic foot ulcer for I think it was 2 years. When she got to us, the doctor said, listen, we have to amputate your foot. She had recurring infections over that ulcers, and they were about to amputate the foot. So as I told Dr. Sonia, we started developing a protocol for her, since we saw that PRF worked miracles in the mouth, you know. So we developed a protocol, and we set out to close her wounds, right? Because it was her last chance. Well, she had diabetes, chronic renal failure, hypertension, and dialysis. This is probably one of our toughest cases that we've done, because she knows that she had diabetes, but she didn't take care. You know, she ate sweets and a lot of fats, and so she didn't take care of herself, actually. And probably we took a longer time with her due to this reason, because we took like probably around 3 months with her, or 3.5 months, to close her wounds. When we have done this kind of wounds with some other patients that do cooperate with the blood sugar control, if we control the sugar in their patients, their healing will be faster, right? So we took a little bit longer with her, but take a look at this. This is a month and a half in her treatment, month and a half, right? It's almost closed. 2 months, right? Take a look at that. It's very, very, very small. And this is 2.5 months or 3 months, I think. And that's how it closed. So PRF does work, does close chronic wound healing. At the moment, we can say that we have 100% of success in all of our cases, but we do need the collaboration of our patients, because it's very important. Because if your patients don't take care of themselves, you know, like their lifestyle and things like that, their healing is going to be always slower. It doesn't matter if you have a diabetic patient. The thing is that you have them under control, right? And this is why I work with doctors in our team, because they do take care of all of that, the blood analysis and on different analyses that they make on our patients. And all of this because we want a faster and a greater quality healing with our patients, right? And just to close, this is something that we're doing right now. We are doing a split mouth trial here at the university, and we are extracting impacted third molars, and then one side we do just a normal blood clot, and on the other side we do a PRF clot. And I'm going to show some partial results that we have here. We are doing mRNA markers, and we do have difference comparing the blood clot versus the PRF. Look at this, the type 1 collagen, the osteocalcin, alkaline phosphatase, and RON-X2. So we are getting better results with PRF, right? And with that, I just wanted to thank you for your attention. And this is my contact info. If by any chance you want to contact me, or you want any research opportunities, we are open to work with doctors. We have many different investigation lines or if you have an investigation that you might want to do, we can surely develop a protocol. And, you know, as I said in the beginning, it's always good to work in a team, right? We don't know everything. We know some things, but maybe some other doctor around from somewhere in the world knows something that we don't know, and maybe we can work together. So thanks for the time, thanks for the attention, and we would love to work with any of the doctors who want to collaborate with us. So thank you, Dr. Sonia. Thank you for your attention.
Thank you, Marco, for the wonderful presentation. I have a few questions for you. This is so amazing how dentistry is really actually changing a lot in terms of healthcare currently. And I can see that throughout, from the sleep medicine that we are very highly involved, all the way now that you are doing this contribution with the PRF technology that we're transferring from mouth to other parts of the body. What I want to ask you is, when you have infected wounds, like in the diabetic wounds, what's your approach clinically before you apply the PRF?
Yeah, so the PRF has antibacterial potential. It's been proven, but we always do a wound cleaning and debridement. And if it's infected, we treat it before putting the PRF. But today that's our protocol. But we would like at some point to try the antibacterial potential of the PRF, because it does on patients, right? On patients, because in vitro, we do know that it has antibacterial potential against staph resistant bacteria, methicillin-resistant bacteria, Staphylococcus aureus, also with periodontal bacteria. So it does have a antibacterial potential. But today, we first clean the wounds and we do give antibiotics before applying our PRF.
So you give intraoral antibiotics as well?
Yeah. So we just had one case where we had to give IV antibiotics for one of our patients who was in a very, very bad shape, So for that one patient, the doctors here in our team gave him IV antibiotics.
Yeah, we were talking just before the presentation started, and we were talking about photobiomodulation, which is something you said you just been thinking about it. And I don't know if you familiar with the APDT, which is also the antimicrobial photodynamic therapy that can be used with the same device to do the disinfection, and then use the photodynamic therapy for helping with the healing. Now, you mentioned about the VEGF, the vascular endothelium growth factor being important for increasing vascularization. Now, one of the effects of that photobiomodulation therapy is also increasing this vascularization, which I would imagine that would potentialize this treatment. So what are your thoughts about this association of synergistic effect with lasers and photobiomodulation and like the antimicrobial photodynamic therapy with the low power laser?
Yeah, I was as I was telling you, I was last week on Fort Lauderdale. I went to a course with Bio Prf education, which is Dr. Rick Myron, and they were showing very, very interesting cases with the photobiomodulation, and it's amazing. It's amazing because it's very interesting how it works. All of this, I saw it for facial aesthetics, but it's also applicable on these cases, because it's the same. We do need collagen, we do need VEGF, we do need growth factors, we do need wound closure. It's the same. It's just that we have to extrapolate it to this other field, Yes. And that's what we've been doing, because there is nothing written about this nowhere. So we have to experiment, right?
Correct. Yes, a photobiomodulation for diabetic ulcers and those bed sore that's they've been using quite a lot, quite successfully. But I haven't seen this speed of healing that you were showing there. But what it just occurred to me, if you can use the two techniques together, imagine the optimization we could do that with the synergy we could get. I mean,
it's like a booster, amazing. Right? Yeah.
Correct. Yeah.
I think it will work like a booster, because if they work synergistically, it should work amazingly. Yeah.
Mm-hmm. That's so fantastic. So basically, the patients you've seen in the clinic, 100%, you're saying that you managed to close. There'll be a lot of people that you're avoiding amputation altogether, right? Some of
Correct.
them, they're referred to you because they're like a case for amputation, and they send you as a last resource. Is that how normally comes to you?
Yeah, usually we're the last resort for the patients, but recently our patients have been referring us other patients, you know, like their neighbor or their friend of friends, or so we've been getting more patients referred because now the patients have seen that it works. And since well, the problem is that well, we have only published some of our results, not all of them. The rest will be published very soon, but so not even some doctors know about these results, right? So that's what's difficult, to get the doctors and the patients to believe in the treatment, right?
Yes, yes. We have the same problem with photobiomodulation because they say, but like the light, but it's not hurting, it's not burning anything. How can this low power light do some healing? It's like, sometimes it's difficult for them to understand until they see the result, then they start the word of mouth, right? So I'm very, very impressed with your work, and I'm so happy to hear that another colleague, a dentist, is actually making such an amazing, powerful change, because the number of diabetic patients is so huge and is increasing by day. And imagine with this treatment, if you can avoid it, these people losing their legs, and it's so incredible coming from a dentist. I feel very proud to be to be part of our profession at this time, and thanks to people like you who dare to try to who dare to think out of the box, can make this possible.
Thank you very much.
Yes, I'm really, really deeply impressed. Is anything else you'd like to say, or a message you want to give to our listeners?
Well, yeah, and basically you just said it. We need to think out of the box, right? That's what's gonna take us to another level, and we and the teamwork, because we need people we need our to work with a team, right? And this is why we are always open to work with other doctors, and they have different knowledge that maybe we don't have, and we can also be synergistic with each other. So it's always good to work with other doctors.
Fantastic. So with that, I'll leave you for today. And I'd like to thank you very much for your time, and thank you to the listeners. And remember, you can get your CE credit by joining the link below. And I'll be in touch with you about the photobiomodulation. I'm sure we can do some work together.
That'll be amazing. That'll be amazing, Dr.
Yes.
Sonia.
Yes, it was a big
Thank you very
pleasure.
much.
Thank you.
Thank you.
Appreciate it. Thank you. Thank you all.